Hello friends, today we are going to discuss about the scrub typhus. It is also known as Tsutsugamushi disease. This acute febrile disease is caused by Oriental Tsutsugamushi, which is a small gram-negative obligate intracellular organism. Both polysaccharide bear antigenic relationship to protease OXK, which is thus used in serological tests to confirm scrub typhus. Oriental Tsutsugamushi is transmitted to human by the bite of larva trombiculate mite sugars, which are almost microscopic and often brilliantly colored. That is red. Infected sugars are found particularly in the areas of heavy scrub vegetation during wet season. Therefore, the disease has been called river or flood river when mites lay egg, usually in June throughout the November. The word scrub was applied because the type of vegetation that maintains the sugar mammal relationship, even though the other region also supports the rodent and mites. Scrub typhus is endemic to the part of the world known as Tsutsugamushi Triangle, and this extends from the Japan, Taiwan, China, South Korea, Nepal, northern Pakistan, then New Guinea and Australian state of Queensland and northern New South Wales. In India, the presence of scrub typhus has been known for several years, and the disease is widely spread all over the country and was reported in several states like Haryana, Jammu Kashmir, Himachal Pradesh, Uttaranchal, West Bengal, Assam, Maharashtra, Kerala, Tamil Nadu. During World War II, there was an outbreak for this disease in Assam and West Bengal. In 1995, Indo-Pak War, and in 1990, in the unit of an army deployed at Pakistan border of India. This report showed the resurgence of this disease in India. Oriental Tsutsugamushi invade the endothelial cell to produce the disseminated vasculitis in perivascular inflammatory lesion, which results in significant vascular leakage and ensuring end organ injury. The illness varied from mild and self-limiting to fatal after incubation period of 6 to 21 days, and the onset is characterized by the fever, headache, myalgia, cough, and gastrointestinal symptoms. The classical case description include primary popular lesion, where which enlarge and undergo central necrosis crust to form flat black eschar. This is associated with the regional and later generalized lymphadenopathy. The symptom gradually increase in severity and macular rash may appear on the trunk. If untreated, patient may become stuporous as meningoencephalitis develop, and various cranial nerve deficits have been noted in untreated patients. Then the pulmonary findings are often absent despite radiographic evidence of interstitial pneumonia. Signs of cardiac dysfunction, including minor electrographic abnormalities, first degree heart block, and inverted T waves, can appear. In patients with myocarditis, there may be gallop rhythm, poor quality heart sound, and systolic murmur. Sometimes palpable spleen may be present. Deafness, dysarthria, dysphagia may occur, but are usually transient, although deafness can last for several months. Patients with the untreated disease remain febrile for about 2 weeks and have long convulsions of 4 to 6 weeks thereafter. In children, scrub typhus may be mild or severe. Most patient presents with the fever, regional generalized lymphadenopathy, a single painless ischar, maculopapular rash, hepatomegaly, splenomegaly, and GI symptom may be present. Case fatality rate in untreated patient may be as high as 30%, although death in children are infrequent. It is necessary to determine the predictors that identify the markers of severe disease in order to reduce the mortality, complication, and delay in treatment. The potential markers for developing complications were age. Scrub typhus patient who presented to the hospital without HR, lab findings such as WBC count more than 10,000 and serum albumin level less than 3. So lab studies are usually reveal leukopenia, thrombocytopenia with severe increasing WBC count to normal level. Then there can be coagulopathy, elevation in liver enzyme bilirubin indicating hepatocellular damage and proteinuria. There can be elevation of the creatinine, then the reticulonodular infiltrate. Chest X-ray also revealed transient perihilar peribronchial interstitial infiltrate. CSF examination shows the mild mononuclear pleocytosis with normal glucose level. Owing to the potential for severe complication diagnosis, decision to initiate treatment should be based on clinical suspicion and confirmed by the serologic test. Serological tests have their own limitations in which clinicians need to be aware. Although agreement exists that more than or equal to fourfold increase in antibody titer between two consecutive samples is diagnostic, and such a diagnosis is retrospective and cannot guide the initial treatment. The well-Felix agglutination test, it is the oldest test in the current use and detects the cross-reacting antibody to protease mirabilis. The diagnostic well-Felix agglutination shows more than 4 times rise in titer to protease OX-K and no reaction to protease OX2 and OX19. A single titer of more than 1:160 is also diagnostic. Then about 50% of patients have diagnostic titer, and this test is inexpensive, easy to perform, and results are available overnight. However, it lacks sensitivity and specificity. So, well-Felix test is still used because of its low cost and in condition where other serological tests are not available. Even though this test is not very sensitive, but when positive, it is rather specific test. So the next test is ELISA. ELISA using whole cell antigen and R56 from carp keto and Gillian strain of Orienta Sutsumashi were used. In the study by Jiang et al., trivalent ELISA appear to be superior in terms of sensitivity. And Jiang et al. Describes the IgM capture ELISA carries the high sensitivity and specificity. It is also reliable and useful diagnostic method for early detection of scrub typhus. Besides, large number of sera can be tested at a time. Then the next is rapid flow assay. It consists of single strip where KPR56 protein was conjugated to gold particles as indicator system. Assay R56 from carp, Cato, and Gillian strain of Orienta Sukmashi using electrophoresis. Results are interpreted as positive or negative with presence or absence of 41 kD band on the film respectively. Then immunochromatographic test, a rapid diagnostic test in which serum was applied to the reagent pad of ICT strip. The results were recorded as positive, equivocal, or negative for presence of control and IgM or total antibody lines. Blackcell et al. Assessed the diagnostic capacity of rapid ICT and found that sensitivity and specificity for detection of IgM were 96 and 93 respectively. For the detection of total antibodies, sensitivity was 97, but the specificity was much lower at 71. The indirect fluorescent assay, it is first described by Bonesman. Indirect fluorescent assay has been considered as a gold standard for serological detection of scrub typhus antibody and is also currently the reference standard. The specific serological test for conclusive diagnosis is the detection of significant increase of indirect fluorescent assay in paired serum specimen obtained 2 weeks ago. The endpoint of each IFA titer was defined as lowest serum concentration, demonstrating definitive fluorescence. The test is more sensitive and faster, but costly and antigenic variation is common. It eliminates expense of fluorescent microscope in which fluorescence is replaced by peroxidase. This test has advantages in that any rickettsial strain can be used as antigen, either IgG, IgM antibody. It can be titrated individually, gives permanent preparation, and all cells can be observed. It is easy, however, readings are subjective. Then the next is PCR amplification of Orienta gene. Samples from HR in the blood are useful and may be more sensitive diagnostic tests. Since Orienta Tsutsugashi is intracellular organism, thus the whole blood and buffy coat is considered to be preferred sample for PCR test. Nested PCR test based on the specific primer derived from 56 kD major outer membrane protein antigen of Orienta Tsutsugashi can detect the organism as early as 1 to 3 days of fever phase and is known as 100 times more sensitive than performing single PCR. Then Orienta Tsutsugashi can be isolated and cultured from the patient blood by inoculating into intraperitoneally into white mice. However, it requires biosafety level 3 facility. It is costly and laborious, hence not appropriate for routine diagnosis of scrub typhus. Guinea pig inoculation, scrotal reaction following intraperitoneal injection of blood into male guinea pig. It is a negative in scrub typhus. And regarding complications, scrub typhus involves multiple organ and it is characterized by microangiopathies, focal vasculitis, and perivasculitis. Pulmonary involvement is well documented. Complication of scrub typhus infection with pleural effusion being common radiological finding in 12 to 55% patients. Other pulmonary infections include varying degrees of bronchitis and interstitial pneumonitis. Other pulmonary manifestations include varying degree of bronchitis, interstitial pneumonitis, progress into ARDS, pneumonitis with patchy consolidation, cardiomegaly, pulmonary edema, hilar adenopathy, focal atelectasis, reticulonodular opacities, bronchial wall thickening, and central lobar nodule. So, radiological finding may be of value in differentiating scrub typhus from other febrile illness. The incidence of chest X-ray abnormality in patients with scrub typhus varied from 59 to 78. In their study, Wu et al. Found incidence of chest X-ray abnormality was higher in older age group, and chest X-ray pattern could be different at different stage of the same disease. Patients with abnormal chest X-ray finding had high rate of serious complication such as septic shock, congestive heart failure, acute respiratory failure, severe jaundice, acute renal failure. Requirement for ICU care and prolonged length of stay compared with patient with negative chest X-ray result. Scrub typhus and ARDS. ARDS is well-known complication of scrub typhus, which is rarely reported but serious. Initial symptoms of dyspnea and cough, higher WBC count, lower hematocrit, and higher total bilirubin count, delayed treatment with appropriate antibiotics were significantly predictive variable in this patient with albumin, prothrombin time, and delayed use of appropriate antibiotic being independent predictor. The risk factor for development of ARDS are older age, thrombocytopenia, presence of early pneumonitis. The major cause of mortality is delay in diagnosis, but with appropriate antibiotic therapy, patients usually recover without any major sequels. In study by Wang et al., 11% of scrub typhus patients develop ARDS and mortality rate for such patients was 25%. Pandey et al. Reported the cases of scrub typhus with ARDS who showed dramatic response to doxycycline. In scrub typhus patients should be carefully evaluated for potential progression to ARDS if they initially have respiratory symptoms. Myocarditis in scrub typhus is usually subclinical and therefore many times ignored. So main pathological features findings are vasculitis, perivasculitis, cellular infiltration consisting of primary lymphocyte, plasma cell with interstitial hemorrhage and edema. Cardiomegaly and CHF may be present, which could be secondary to myocardial and pericardial involvement. Gastrointestinal involvement is also frequently reported. Some studies reported a elevation of liver enzyme, hepatic dysfunction with elevation of serum bilirubin. Most patients showed the peak value in their abnormal liver function test 2 weeks after onset of symptoms. The major endoscopic features in scrub typhus are superficial mucosal hemorrhage, multiple erosions, and ulcers without any preferred site, and unusual vascular bleeding. Acute pancreatitis associated with pancreatic abscess in patients with multiple organ failure have been reported. The mechanism responsible for development of acute pancreatitis may involve intrinsic inflammatory process via vasculitis, but precise nature of this mechanism is not well understood. Hyperamylesemia and liposemia have been reported. Many studies reported renal failure as one of the major complications, and one study showed during febrile phase of the illness, 20% of patients had abnormal urine analysis showing proteinuria almost exclusively. The renal pathology usually showed characteristic focal interstitial lesion, cloudy swelling of tubular epithelium, and occasional evidence of severe vascular damage and glomerular injury. Central nervous system complications range from the septic meningitis to frank meningoencephalitis. Meningoencephalitis is constant autopsy finding in fatal cases of scrub typhus and is present in 10% of children. Now, regarding differential diagnosis, scrub typhus is recognized cause of obscure topical fever, especially in children. The differential diagnosis include fever of unknown origin, enteric fever, typhoid fever, dengue fever, other rickettsiosis, tularemia, anthrax, dengue, lepto, malaria, and then hemorrhagic fever, infectious mononucleosis. Headache may mimic trigeminal neuralgia. Regarding prognosis, treatment, prevention, and control, the case fatality rate for untreated classic case is 7%, but would probably be lower if mild cases were diagnosed. Poor prognostic factor include requiring care in intensive care unit, high Apache score, and the absence of HR. According to some report, the rate of HR formation varies and is much less in Indian subcontinent and could be related to the different virulence, load of pathogen, and host immunity. Concurrent scrub typhus may inhibit the replication of HIV, and HIV infection does not appear to influence the severity of scrub typhus. Then therapeutic trial of tetracycline and chloramphenicol is indicated in patients in whom diagnosis of scrub typhus is suspected. Differences should occur within 24 hours. The recommended treatment regimen for scrub typhus is doxycycline, that is 2.2 mg per kg BD or IV, maximum 200 mg per day for 7 to 15 days. For prophylaxis, 200 mg may be taken as single dose. It does not accumulate significantly in patients with renal impairment. Recent reports suggest the natural resistance to doxycycline and other antibiotics makes selection of appropriate antibiotic therapy difficult. Alternative regimen include tetracycline, that is 25 to 50 mg per kg per day dose divided every 6 hourly, maximum 2 gram per day, or chloramphenicol, that is 50 to 100 mg per kg per day divided every 6 hour IV, maximum 3 gram every 24 hours, and 500 mg QID orally for 7 to 15 days for adult. Therapy should be continued for a minimum of 5 days and until the patient has been afebrile for at least 3 to 4 days to avoid relapses. Chloramphenicol is best avoided during pregnancy and reduced dose should be given in hepatic impairment. Ciprofloxacin is the quinolone antibiotic that is effective against Oriental Tsutsugashi. However, there is substantial amount of data demonstrating ciprofloxacin is not efficacious in the treatment of scrub typhus. Another alternative treatment is azithromycin 500 mg oral for 3 days. The trial showed that azithromycin may be as effective as and that rifampicin 600 to 900 mg per day is superior to doxycycline in such cases. The retrospective analysis in Korean children with scrub typhus showed roxithromycin, that is 150 mg twice a day, was as effective as either doxycycline and chloramphenicol, suggesting a role as alternative therapy for children or pregnant. Rifampicin reduces the duration of fever by 1 day when used with doxycycline. Intensive care may be required for hemodynamic management of severely affected individuals. Prevention is based on the avoidance of sugar that transmit to oriental Sutsumashi, accompanied by insect repellent and by the use of protective clothing impregnated with the benzyl benzoate. Diethyl toluamide preparation are also effective, and applying this chemical to socks is especially important in preventing sugar. Infection provides immunity to reinfection by homologous but not heterologous strain. However, since natural strain are highly heterogeneous, infection does not always provide complete protection against the reinfection. Vaccines were developed and tested, however, no single antigen has been identified that induces protection against all antigenic diverse strain of Oriental subspecies. For short exposure, chemoprophylaxis with doxycycline can prevent the disease but permit infection. Prophylaxis for scrub typhus with doxycycline had shown promise when started before exposure to infection. Now, scrub typhus in pregnancy. The clinical manifestation of scrub typhus in pregnant women are similar to those with a non-pregnant. Studies reported that scrub typhus in pregnancy may be associated with increased fetal loss, preterm delivery, and small for gestational age infants. There have been reports of vertical transmission from transplacental infection and transmission in perinatal blood-borne infection during labor, causing neonatal scrub typhus in mother and acute febrile illness during pregnancy. So, diagnosis of scrub typhus during pregnancy, same as non-pregnant female, and is based on exposure, history, clinical symptom, and confined serological study. The standard therapy for scrub typhus in non-pregnant adult is doxycycline and chloramphenicol. However, doxycycline it is a class D drug and has been associated with fatal risk and contraindicated in pregnancy. Chloramphenicol is classified as class C drug and is prescribed with caution in late trimester pregnant female because of increased risk of fetus at the time of delivery. Sui and Kovac demo reported that pregnant females who were successfully treated with minocycline, but it is difficult to define safety of its use during pregnancy. The single dose of azithromycin was successfully used in 9 pregnant females suffering from scrub typhus without relapse and favorable pregnancy outcome. Importantly, there is little evidence to suggest that azithromycin causes harm to developing fetus. Azithromycin seemed to be effective against the scrub typhus because it effectively penetrates polymorphonuclear leukocyte and macrophages, which are target cell for oriental subsubmission. In addition, a long tissue half-life and long-lasting post-antibiotic effect of azithromycin may explain no relapse despite the use of single dose. The use of ciprofloxacin in pregnant female resulted in miscarriage. Therefore, ciprofloxacin should be selected with caution for the treatment of scrub typhus, especially during pregnancy. Now, the scrub typhus is clear disease where disseminated vasculitis, perivascular inflammatory region result in end organ injury. Even though the disease showed dramatic response to appropriate antibiotic, these serious complications can occur and most of them prove to be fatal. So most of the ICUs, these patients are usually admitted when such a complication have already progressed, mainly to undiagnosed, misdiagnosed, and hence left untreated. In ICU, aggressive management of such a patient is imperative to prevent high mortality associated with these complications. Preventing sepsis and multi-organ failure can be possible in ICU with specific treatment protocol and supportive management. Hence, anesthetists and intensivists have to be aware of such a situation to prevent morbidity, mortality associated with this disease. Thank you.